You're listening to the Mother to Baby podcast, medications and more during pregnancy and breastfeeding. Ask the experts with your host, genetic counselor and mom of three, Chris Stallman.
Hello again, and welcome back to the Mother to Baby podcast. My name is Chris Stallman, and I'm a genetic counselor, mom of three, almost four, and a teratogen information specialist. What that means, in case you're new to our podcast or need a refresher, is that I give information about exposures that can happen during pregnancy or breastfeeding. And an exposure can be anything that a woman comes in contact with pregnancy. So it could be things like over-the-counter medication, herbal supplements, prescription medication, sometimes even questions about things like hair dye or nail polish. At Mother to Baby, we answer them all. We are a non-profit service, so that means all of our services are free to you. And we do answer questions for patients and their healthcare providers about anything that you can think of. We answer them over the phone, through email, through chat, and through texting. And we also have a lot of good information along with the ways to contact us on our website, MotherToBaby.org, again, which is completely free to you. On today's episode, we are going to talk about gestational diabetes, something that people certainly have heard about. I know it's something certainly that women go through during pregnancy, or you may know someone who has gone through it. And as our guest, we have a return guest from Mother to Baby Utah, Alfred Romeo, who is a registered nurse who has a doctorate in health promotion and education. He is the co-chair of the research committee for the Organization of Teratology Information Specialists, that's OTIS and Mother to Baby. And his experiences include work as a nurse in newborn intensive care. He teaches college health education classes. He does training for medical homes in order to improve services for children with special healthcare needs. He trains young adults with disabilities in leadership and advocacy. He helps families learn about child development. And if all of that was not enough, he also works at our Mother to Baby Utah service. So, Alfred, thank you so much for joining us again. How are you?
I'm doing great. Thank you for having me on. And yes, I used to work in a newborn intensive care unit, so I've seen babies, with some of these issues, and we'll talk about those, but it's very difficult for families to deal with some of these situations. So what we're talking about is not only the effects to the baby, but the family overall.
Absolutely. And for full disclosure, right now I'm in the late third trimester of my pregnancy, and this is a question that I get a lot as a provider, and one I give a lot of information about, but at the same token, I'm also a patient. I too was recently diagnosed with gestational diabetes, so I am definitely interested to ask you some questions about this.
Perfect. Where would you like to start?
Okay. So the number one thing that I hear and really absolutely crossed my mind when I was told that I have gestational diabetes is I didn't have diabetes before in any other pregnancy, and I also didn't have diabetes outside of pregnancy. So why do I have it now that I'm pregnant?
So researchers aren't exactly sure why, but there are some different things. It's probably a combination of some of these things. As you know, and as our women listening know, there are hormonal changes during pregnancy. So the gland that produces insulin, it is regulated by different hormones. So during pregnancy, all of those hormones are going through changes. The pancreas that produces that insulin is going through changes. So that may be part of it. There also may be a genetic component to it. Some people have type 1 diabetes. Some people have type 2. Yes, some people have gestational diabetes. So there's maybe a genetic predisposition. And then, of course, we'll talk about some of these other ones. Weight issues can be part of it, and previous history of gestational diabetes can be part of it. So it's probably not just one thing, but a combination of different factors that happen for a particular woman.
Gotcha. Okay. So if you're someone who's diagnosed in pregnancy only, is the diabetes going to continue after you deliver the baby?
it usually wraps itself up. It usually discontinues a few weeks to several weeks after she's given delivery. So mom gives delivery to the baby, and then a few weeks later, that gestational diabetes, those symptoms kind of go away. But in the future, she is more likely to have type 2 diabetes, and she is definitely more likely to have gestational diabetes with the next pregnancy. So it does resolve, but there is the possibility of having diabetes in the future.
Okay. That also makes sense. And so now I guess the big question is, like you said, there are different types of diabetes, so you can certainly get it in pregnancy, but we know little kids, 5, 6, 7 years old who get diagnosed with diabetes, that's usually type 1, and then weight related, and other conditions can be type 2. So my question is, there's lots and lots of women who have diabetes of any kind and go on to have a healthy pregnancy. And there's some who don't. So what are the risks to my baby? And is it with all types of gestational diabetes? Or if my sugars are in control, is that going to be better for the baby and for the pregnancy?
In general, the better control that you have, the better. But let's take another step backwards. So for any woman, there is always about a 3% to 5% chance of having a baby with a birth defect. That's where everybody starts. And then if they have uncontrolled diabetes, whether it's from type 1 diabetes or type 2 diabetes before she gets to pregnancy, in that first trimester, if she has uncontrolled diabetes and her A1C is greater than it should be, then she has somewhere, depending on the amount of control, 5% to 20% increased chance of having a baby with a birth defect. So there are greater risks, and there are different risks for gestational diabetes because it happens later in pregnancy. And we'll talk about some of those birth defects versus some of those later complications. But the uncontrolled diabetes early in pregnancy is the one that does produce those greater risks, up to 20% for birth defects.
And what kind of birth defects are we talking about here?
So these are birth defects of some of those structures that develop early in pregnancy. So mom may not even realize she's pregnant before these birth defects happen. That's why we want mom to have control of her diabetes throughout the reproductive years. For example, the heart and the spine are developing from a few weeks into the pregnancy to almost the end of that first trimester. So by the time she makes her appointment with her doctor and gets in at 10 to 12 weeks, those structures are already formed. If she didn't have good control of her diabetes, she could have birth defects of some of those structures, the heart, spine. Also, there could be defects of the bones, specifically the long bones, the urinary tract, reproductive tract, and digestive system. So uncontrolled diabetes is one of the most common causes of preventable birth defects. So it's really important to have that control before mom gets pregnant.
And that's actually a great point that you mentioned, that in some cases it's something that can be prevented, because I know that January is National Birth Defects Prevention Month, and there are a lot of birth defects that can't be prevented. As you say, there's always a background risk, but it is nice to know that if there is something that women can do to help reduce that risk, then it's good information to have, I think.
Yes. So uncontrolled diabetes leads to about half of those preventable types of birth defect. The research shows that out of all of those different preventable type of ones, half of them are from uncontrolled diabetes.
Okay, so we know that uncontrolled in the first trimester increases the risk, but you did mention later in pregnancy complications. So what would that look like?
Sure. So whether later in pregnancy, whether it's from type 1, type 2, or gestational diabetes, some of those other complications include increased chance for miscarriage, stillbirth, preeclampsia, which is high blood pressure, which can cause a variety of complications for mom and the baby, too much fluid around the baby. And then, as I mentioned, I used to work in a newborn intensive care unit, and babies can be born large. They have too much sugar, so they have that extra medium to grow. And I've seen 10-pound babies, and they have a difficult time breathing.
Wow, 10-pound baby. I mean, I'm pretty sure everybody's heard about that. So-and-so had a baby that was 9.5, 10, 11 pounds. That seems like a very large baby.
It is a very large baby, and that makes it difficult, like it says, for the baby to breathe. They have increased chance of having jaundice, that yellowing of the skin, low blood sugar. They're used to having that higher amount of blood sugar, so their body kind of gets used to it. But then when they have the regular amount of blood sugar, their body interprets it as a deficiency, and so they have low blood sugar. So there's a variety of complications. They may need other assistance. They may be in the newborn intensive care for a while. They need breathing assistance. So yeah, there's a variety of different complications that could happen. And then just being in the newborn intensive care unit, being born and having those complications can lead to secondary issues. So we definitely want to prevent that and help baby have that best first start.
Absolutely. And it's scary too. I mean, already as someone who's given birth a few times, labor and delivery can be kind of scary. It's wonderful you get to hold your baby, but anytime there's, your baby needs extra care, and babies usually get the best care, and they need extra care, but anytime the baby's away or needs special treatment, it gets a little scary, to have your baby not with you all the time because they need extra treatment. So I'm sure it also, puts stress on the family to have the baby have to be in the intensive care unit.
Absolutely. So we want mom to make sure that she's controlling her diabetes. That will decrease that risk for not only those birth defects, but those problems later in pregnancy, to have it controlled.
That definitely sounds like a good thing. And I know that there's quite a push to do that. In fact, because when I got pregnant most recently, I was not at my ideal body weight. I was a little bit above. So what they did was, typically they do the blood testing and the sugar testing. So what they do, in case anyone has not experienced that or isn't familiar with it, so usually around 24 to 28 weeks of pregnancy, what they do is have you go into a doctor's office and you drink a really, really, really sweet, sugary drink. These days it's either fruit punch, and I've had orange as well, and it's very sweet. They have you drink it, and then they take your blood, and they call that the glucose tolerance test. And that's the first step. So you drink your drink, you wait an hour, they take some blood, and then if you don't pass that test, they can have you go back for a 3-hour where you have to give blood multiple times over 3 hours in order to see if you have diabetes or not. And so for me, because I was above my ideal body weight when I got pregnant, they didn't want to wait till 24 weeks because they were concerned that I would end up with diabetes. So they did it for me at week 12. And actually I passed and did okay. And then it was around week 25 that we did it again, because they knew that, now the risk was back for me to also develop diabetes. So they did it again. And unfortunately, I didn't make it that time. But the good news is, even though it didn't come up positive for me in the first 12 weeks, I know that a lot of providers think about some of these factors. Like you said, there are many things with weight being included in there, and they immediately pinpointed that I might be at higher risk, that and because of my age, because I'm over 35. So I know that too in some cases can play a role.
Right. It's a very delicate balance. We want women to gain weight. We expect women to gain weight during pregnancy. Baby has to grow, and baby is going to be a certain amount of weight. We have extra blood volume and all of those things. So we encourage women to meet those weight gain goals during pregnancy. We definitely don't want them losing weight, but it's a balance between gaining the right amount of weight and not having too much weight that you, yes, put yourself at risk for diabetes.
And when I went back this most recent time, because I'm so far into the 3rd trimester, my provider, who was just absolutely lovely, had said, we have you under control now with medication. We're going to talk about that next time, actually, ways to reduce risk, ways to treat during pregnancy. But she said, even though it's okay right now because the baby's getting bigger, it may not be okay. Even if you eat absolutely perfectly, you're drinking all your water, you're taking your medication, you're exercising the way that your doctor tells you to, even then your blood sugar can still go up. And really what I took from that conversation with her is, when I'm doing everything correctly and it still goes up, it's not my fault. Meaning that they want to control it, absolutely. But when I'm doing everything that I can, sometimes even still, it might be out of our control.
Correct. And like we said, to start off with, we are not sure exactly why, but there's a lot of different hormonal changes. There's genetic causes that may be involved. So it's a very complex process.
It definitely is. And so that's why, if you don't mind, Alfred, we're going to stop right here because I think we covered a lot of ground in this first session, but I was wondering if you would be open to coming back and talking about some other questions that I had.
That would be excellent, yes.
Okay, great. Well, thank you very much for being on. And again, glad to have you back this first time, and we will chat again in the near future.
Thank you, and our listeners can visit us at MotherToBaby.org.
Yes, perfect timing. Thank you. So, as Alfred said, MotherToBaby.org is our website. Again, free to you. So not only do they have all the different ways to contact us, but we also have over 250 fact sheets written in English and translated into Spanish about all manner of things. And actually one of them is about diabetes and some of the medications that are used to treat diabetes. Those are also free. And then on our website, you can find out how to contact us. So if you have questions about the podcast, or if you want to be on the podcast, you can always email us at contactus@mothertobaby.org. If you want to call, which is absolutely wonderful, we love to get phone calls. You can reach us toll free at 866-626-6847. You can also text us at 855-999-3525. Also on our website, you can find the chat feature, which allows you to chat with a mother to baby expert live during chat hours. And so, wrapping up for today, thank you, listeners, for joining us. Please remember that you can find this and our previous Mother to Baby podcasts on iTunes, Spotify, or however you listen to podcasts. And don't forget to subscribe so that way you never miss a new episode. In the meantime, thank you for joining us. We'll hope to see you again soon when we have Alfred Romeo back on the show for more talk about diabetes. But in the meantime, remember, Mother to Baby is here for you. Take care.
Mother to Baby is a service of the nonprofit organization of Teratology Information Specialists and supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. It's made possible through generous donations from listeners like you. To learn more about Mother to Baby, please visit mothertobaby.org.